Welcome back, Parkinson's community. I'm Nicole Hanna, and this is the host of the Living Well series for Friends of Parkinson's. We're glad to have you back today, and I can't wait to introduce you to Carolyn Schmidt. She's the Executive Director for Seasons Hospice and Palliative Care. Having been and served in the healthcare community for over 20 years, I personally am a huge advocate for hospice, palliative care, and all that it has to offer. There's so many misunderstandings and misconceptions about all that hospice and palliative care have to offer to our residents, our patients, and our clients that we serve among Nevada and nationwide. So I'm looking forward to introducing you and letting you learn a little bit more about the hidden secret of hospice. Carolyn, thank you so much for joining us today.
Thank you for having me.
I would love for you to tell us a little bit more about who you are and all that you bring to Seasons Hospice and the services you provide.
Okay, I'm Carolyn Schmidt. I am a nurse, an MBA. I've been working in the Las Vegas hospice community since 2004. I've been with Seasons just about 2 years, and I just really feel like hospice is my calling. I also worked in skilled nursing for a little while. I worked in a pharmacy in college, but hospice just really speaks to me. I think it's the best place to get that quality of care and that depth of the relationship that is so often missing from the acute level of care.
Agreed. Now, in this day and age, so many of the families that I serve have no idea about hospice and just how much there is, even with the use of palliative care. Can you tell us a little more about that?
I can. So I always say if hospice was called anything else, people would line up for miles to receive the care, because it's a huge set of support services that you don't get in any other system. So hospice provides care for people who have an illness that is not getting better. So even though they've had treatment, their illness continues to make them decline. They're losing weight. They're having recurrent illnesses, they're in and out of the hospital, they're losing functionality, or they're just giving up hope. And that's kind of the number one sign for us that it's time to start talking about hospice. So it's a philosophy of care that really changes the focus from do everything you can to get this patient better, even if it hurts, even if they're away from their loved ones. Especially in the pandemic environment, you have people that are hospitalized for months on end without the touch of their loved one, and that is so crucial to well-being. So hospice takes that whole philosophy and puts the patient at the center and the patient's well-being at the top of our goal pyramid. And then the patient is surrounded by their friends and family, and hospice comes in with nurses, physicians, CNAs, social workers, we have music therapy, a counselor. All of these people come in to make sure that the patient is not suffering with pain or anxiety, that they're connecting to their long lost loved ones, that they're in the environment they want to be in. Most people do not want to die in a facility. They want to die at home surrounded by the people that they love.
Thank you. We're going to be back in just a few moments, but I think that Carolyn has brought such a great insight to the high level of what hospice is, and also understanding that these services are available wherever the patient is. So they come to you and support you in whatever environment you're in. Stay tuned after this break to learn more about all that Seasons has to offer and just what hospice is and how it can support you, your family, your caregiver in any environment you're in, and based on what your needs are. They take this off your plate and make the life easier so that you can focus on you and your loved one. We'll be right back. Welcome back. We've got the best guest with us tonight with Carolyn and explaining some of the misconceptions of hospice, but also educating us on all of the things that are available. This is something that I'm truly passionate about, and it's wonderful to hear that hospice is not only supporting the patient, but they're coming in to support the caregiver. Having served in this community for a number of years and from coast to coast in healthcare and geriatric practice, it's wonderful when I can educate families about the benefit of hospice and most importantly to support and serve that caregiver as well, preventing burnout, providing social services and grief counseling throughout the journey while also holding the hand and comforting the patient every step of the way. Carolyn, thank you again for joining us today.
You're welcome.
When it comes to Seasons Hospice, what are some of the questions that families come to you with, and how can we educate the folks that are listening to us today so that they can get your services sooner?
I think the biggest question that we get, and one of the biggest hurdles for people accepting the care, is, do I have to give up everything? People still have this misconception, even in the healthcare community, that hospice means a dark corner and a morphine drip. And it is absolutely not that, especially for Seasons. We have an open access program, so we meet patients and families where they are. Of course, we're going to help them process what's happening and help them move forward, but I'll give you two quick examples. I had a patient who was referred a month ago, and he's on peritoneal dialysis. Typically, hospices will not touch that, but we accepted the patient because he is still declining. His family desperately needed our help, so we supported the peritoneal dialysis in the home. He received all of the medical equipment, all of his medications are delivered right to his door. He gets visits every day of the week from a CNA. A nurse is available 24/7, as is Dr. Heineman, the medical director, by phone. So we've been able to keep that patient at home, and he was in and out of the hospital 3 times in the 2 months before he was referred to us. The second favorite patient I have right now is a young lady who thought she was on the lung transplant list. And typically you wouldn't take a person on a transplant list onto your services, but we thought she was suffering. She has 2 little boys and she desperately needed help. So we took her under care under our open access program. Lo and behold, she wasn't on the lung transplant list, so our social worker and nurse have worked very, very hard, and she will be leaving next week. We'll be signing her off because she is pursuing aggressive treatment, but we got her on a lung transplant list, and she is actually pursuing that goal. So hospice is not always about giving things up. It really is. I wish when people would think about hospice, they would think about what is going to give me quality of life? What's going to give me peace of mind? That's what hospice is about.
I couldn't agree more. I think that you've just touched on so many things that really debunk a lot of the visions of hospice being a final phase or a final step. And I love that you bring in the creativity and thinking outside the box. So many folks go through this checklist of what qualifies or constitutes hospice or receiving an order, and other folks don't realize the many things that you can do to support them and that they can go off hospice. Can you elaborate a little bit on folks that may improve or want to seek aggressive treatment and the support that you can offer even temporarily to get them there?
Absolutely. A lot of times patients will come onto hospice, and to be on Seasons Hospice, you do not have to sign a do not resuscitate order. So the Medicare guideline to sign a patient onto hospice, you do have to have a physician's order. And the Medicare guideline is that it's a reasonable prognosis of 6 months or less. But I've been doing this a long time, and nobody knows the grand plan. Nobody knows their exact time, so we just take every day as it comes. And so many times with patients, we'll see them improve because the caregiver is getting the support they need. The patient is getting their symptoms managed. We're bringing in the supportive care team to help them with those kind of existential pains of the heart that medicine can't touch. And so you get all of that team on board, and the patient lives longer, and sometimes they improve. They improve so much that we have to sign them off. And there are lots of research studies that you can look up online that show that patients tend to live longer on hospice care than without.
I've personally seen that, so thank you for that.
You're welcome.
The one last question I have is, families come to me frequently about the cost. We know as our health starts changing, as we age, the cost of living and the cost of taking care of ourselves can change dramatically, especially with other chronic illnesses. What does hospice cost, and what would that look like to receive your services?
So for senior citizens, it is the one golden thing the federal government has done for us. Hospice costs nothing for someone with Medicare or with Medicaid. Nothing. There aren't any copays, and it includes everything. The medical equipment, the staff, the medications that are delivered right to your door, the 24/7 on-call support of a nurse and physician and social worker. It covers everything. For a patient who has commercial insurance, there are sometimes copays, but Seasons has a foundation that's attached to the company that helps us cover patients who are in need of hospice care that don't have the financial resources to pay for it.
And how would one in the community go about reaching out to Seasons to learn more?
So you can always go to the website, it's seasons.org. You can also just look up the phone number, it's 702-625-9109. Call us and we'll help you with everything else.
Carolyn, thank you so much for coming on tonight.
You're welcome.
Community, I just cannot tell you enough how much I support and preach about hospice services. Having started as a hospice liaison in the mid-90s, I've watched this service and the support change dramatically as our communities have changed, as well as the need of our geriatric population has changed. Should you have any questions, concerns, or hear something that you want to learn more about, it's never too late to call and ask. You can ask your clinician, you can call Seasons, but most importantly, you can have the care and support that you need, and as you've heard here, at zero money out of pocket, and getting the comfort and the peace of mind that everyone truly deserves. Welcome back, Parkinson's community. I'm Nicole Hanna, host of the Living Well series for Friends of Parkinson's. I'm excited to announce that we have a guest tonight, Dr. Eric Farbman. He's going to elaborate on who he is, all that he does, and how he's improving the lives of the community that he serves. Thank you for joining us tonight.
Thanks. Thanks for having me.
Can you tell me a little bit about who you are and all that you're doing in our community?
Sure. So I'm a movement disorder neurologist. I moved to Las Vegas in 2006 from Pittsburgh. And so I'm a neurologist just like any other neurologist in town, but I did extra training specifically in movement disorders, which are diseases where people have involuntary movements other than seizures. And the most common disease I see, most common disease I see is Parkinson's disease.
So knowing that we have a climbing number of individuals being diagnosed with Parkinson's, what does that look like for you, and what can you elaborate on this disease and its increasing in numbers?
Yeah, so there definitely does seem to be an increased number. I think some of it is the aging of the population, but it's probably more than that. We're not entirely sure. Keep in mind, James Parkinson described it before the Industrial Revolution, right? So it's more than just, pollution or things like that. But having said that, I think there's a lot of reasons to be optimistic if you get diagnosed with Parkinson's.
That was my next question. Thank you for leading me into that. So many of the folks I work with in the geriatric population with dementia and Parkinson's and other deficits and diseases that we're facing. The question is, I've been diagnosed, now what? A lot of what we find out there is not positive. It's not necessarily supportive or even educational. It's a lot of negative. Help shed some light on getting diagnosed with Parkinson's and some of the things that we can do that are on a different plane.
Yeah, so obviously nobody wants to be diagnosed with anything, but I feel like if you have to be diagnosed with something, Parkinson's might not be the worst thing in many people. First of all, we do have a lot of research and a lot of treatments. In neurology, there's a lot of diseases, like I treat Huntington's, we don't have much for that at all. Or some other things, we have zero. Parkinson's, there's, I'd have to count them, but probably something like 20 FDA-approved treatments. Also, there's a lot of research. we have research trials going on. There are others worldwide, both on medications, on causes, on other non-medical treatments. Of course, there's a lot of advocacy. I mean, this Friends of Parkinson's is a good example, but it's not the only one. And so there's a lot of advocacy nationally, both on from a patient point of view, like Friends of Parkinson's, but there's also groups like the Michael J. Fox Foundation, more on the research side of things. So there's a lot of reasons to be optimistic. You know, if a person doesn't have cognitive problems, the life expectancy in Parkinson's is not changed. So those are some of the reasons I think it's positive.
Thank you for that. Folks, we are going to take a break, and please stay tuned. We're going to hear more from Dr. Farbman, learn a little bit more about his participation with Parkinson's, learn more about what he's doing to serve this community, and also how he can be of service to you. We'll be right back. Welcome back. Tonight we are interviewing Dr. Eric Farbman and learning so much more about Parkinson's, the movement disorder clinic, and the movement specialty that he provides to all of those that are affected by Parkinson's, as well as other diseases that we have not yet explored. While we're going back to recap on some of the conversations that we previously had, Dr. Farbman, you mentioned information about some of the different medications that are currently out on the market, 20 FDA and plus medications that are being used. Now, the burning question that is on everybody's mind that I'm getting calls about is really understanding more about treatment options through the use of CBD or THC. Can you elaborate on that use of treatment?
Yeah, sure. It's funny. I get asked about that literally every single day. One time, even from my parents. You know, there's a lot of research going on. Right now, we don't have a lot of evidence for it in Parkinson's. The first study that I'm aware of was around 1990 in the UK, where they actually gave people joints to smoke, and they didn't get better. There are studies where people know that they're either on marijuana or CBD, and they seem to get better. But when these studies are blinded, when the people don't know whether they're on CBD or a sugar pill, they don't seem to get better, at least in terms of movements or walking. There is some mild evidence that it might be helpful in hallucinations, actually, in Parkinson's, if a patient has that. There's some mild evidence for it in pain in Parkinson's. People have probably heard about marijuana and pain in general, and there's a little bit of evidence. The bottom line is, I would not recommend it at this point outside of a research trial. Now, we live in Nevada, so Nevada, it's legal recreationally. So a patient says to me, I want it, I don't have to give them a prescription and they can go get it. But it's not cheap, and I would not recommend doing that. One thing which I forgot to mention, I should mention, the difference between marijuana and CBD. Marijuana takes out most of the, CBD takes out most of the psychoactive parts of the marijuana, but cannabidiol is in marijuana.
Thank you for elaborating.
Yeah.
Now, overall, the approach of treating this disease and the continuum of care has multiple facets. Can you walk us through a little bit about all of the different areas that can be impactful or beneficial when affected by this disease?
Yeah, I hope we don't run out of time, but I can do that. So, first of all, there are, of course, non-medicinal things. Probably the most important thing is exercise. We know that exercise helps keep you loose and flexible, which is important in Parkinson's, but it's also probably helpful on the brain in slowing the disease down. So, you know, everybody can do it. You should do the exercise that you'll stick to. You know, you don't have to train for a marathon, but do something that you enjoy. Certainly, as we mentioned, there's a lot of different medicines. I don't know how much detail you want me to go into, but there are medicines that are sort of lighter, they're more heavier, depending on what the patient's symptoms are and what other problems they're having. There are medicines that are approved for sort of associated symptoms of Parkinson's. So even though we think of Parkinson's as like shaking, rigidity, the motor symptoms, there are non-motor symptoms, such as low blood pressure with lightheadedness or hallucinations. And there are medicines that are FDA approved for those type of conditions. And finally, there are more aggressive therapies. There are surgical therapies. There's an infusion of the gold standard medicine, levodopa. There's brain surgeries, which are essentially brain pacemakers to try to treat the symptoms. And certainly not everybody needs everything, but there's different combinations for everybody.
What are some of the things that you're using or recommending at this time that you're seeing the greatest benefit from?
Well, the greatest benefit is probably with carbidopa levodopa, which the medicine basically came out in 1972, but still the gold standard medicine. There are some new formulations of levodopa which may make it work a little bit better, but even the generic carbidopa levodopa still works really well. We have some of the other medicines, some of the smaller guns that maybe don't give as much benefit in the immediate term as levodopa, but there's suggestion that it might slow the disease down. So I often prescribe those. And then we have some medicines that are not oral. They're either a shot or inhaled, or a new one actually that's under the tongue, that are sort of designed as rescue therapies. So if somebody's generally doing well, but suddenly has a downtime, they can take this and hopefully turn on very quickly.
Now, one of the things I just want to use to educate our audience is on time and off time or downtime. Can you elaborate a little bit about that so folks can understand?
Yeah, so I probably already mentioned it already many times, but on time and off time are the terms that we use. On time is when the medicine is working, patient's doing well, maybe not 100%, but they're kind of close to feeling normal. Off time is when the medicine runs out of their system. They're sort of like, when they're walking, it's like walking through quicksand, walking like the Tin Man. Now, this isn't something that newly diagnosed people usually feel. They sort of feel on most of the time. But as the disease progresses, they take levodopa, it works, but then it wears off. And you get these, you're on, you're off, you're on, you're off. And the goal, of course, is to keep somebody on.
Thank you so much for elaborating. I get that question a lot these days.
Oh, okay, sure.
Now, knowing that all of your expertise is also serving on the Friends of Parkinson's Medical Board, can you give us a little insight to what brought you to Friends of Parkinson's and the expertise that you bring to the board?
Well, I've been with Friends of Parkinson's since the inception, and basically, Friends of Parkinson's is an advocacy group, but there has to be some science behind it. For instance, if we're doing a presentation to patients, we don't want, anybody can come and say, hey, I have this and this will, cure Parkinson's or treat this. And we want to make sure that we're giving out legitimate information. And so that's sort of my, purpose with it. I also help lead some of the sessions because this is what I do, but we also want to make sure that whatever sponsors, vendors, anything that's involved is scientifically based and not just some charlatan, I guess.
Understandably. I know that they are very lucky to have you serving on the board. What are some things that you can see on the horizons with Parkinson's and with some of the treatments that are coming behind?
Yeah, so I mentioned earlier, unlike some diseases, there is a lot of research in Parkinson's. There's at least 2 medicines that have been approved this year. One is sublingual apomorphine, which is a medicine designed to try to turn you on quickly. It's an apomorphine strip under the tongue, sort of like a Listerine strip. The other is a medicine, the chemical name is opicapone. It's designed to be used in conjunction with levodopa to make it last longer. Now, neither of these are yet in pharmacies, but they were both approved by the FDA, so, neither of these are home runs, but it's nice to have extra tools.
Agreed.
There are also some new batteries with deep brain stimulation that have newer characteristics. Some of it's pretty technical, and I won't get into it, but it may allow better treatment of symptoms when people have deep brain stimulation surgery. Those are probably the main treatment things, Honestly, some of our research this year has been delayed because of the COVID-19 outbreak, but we do have studies back up and running. I'm at Roseman University, and we're doing a study on a long-acting formulation of levodopa, so people can get the carbidopa levodopa but not have to take it quite so many times throughout the day.
Wonderful. And for someone that was interested in learning more or connecting with you, how would they go about reaching you?
So I'm at Roseman University, which is a small school in Southern Nevada. We have a dental school, a nursing school, physical therapy school, and we're hoping to be credentialed as a medical school soon. We do have some residents, so they can reach me there. I can give you the phone number if you want.
Absolutely.
It's 702-463-4040, and even if they forget my name, if they say they're coming for Parkinson's, they'll know to schedule you with me. And even if people are happy with their neurologist and don't want to change, if they want to be in the study, we can still put people in the study. They don't have to see me clinically to be in the study.
Wonderful.
So,
Thank you so much for appearing as a guest tonight. I truly appreciate all your insight and feedback.
oh sure, thanks for inviting me.
Thank you.
Thanks.
Folks, thank you. You've heard it here, some of the greatest things that not only are on the horizon, but breaking down some of the things that we hear every day in our community for medications, treatments, interventions, and other factors that can contribute to this disease, as well as enhancing the quality of life for ourselves and our caregivers. Thank you again for a wonderful evening, and enjoy your day.